Thank you so much. I'm going to really change things up because these awesome innovations Lifespan is able to participate in and take advantage of. But really what I'm going to talk about today is the Aging Service Network. The work that you and I do every single day, and how with some tweaks we have been really able to prove that the Aging Service Network can reduce hospitalizations, emergency room use, and observations. So my typical 3-hour talk will be 8 minutes. Oops, now I'm... In short, I'm going to tell you that for decades, because I've been working at Lifespan for decades, I've been frustrated that we have lived outside the medical community. And I knew that if we had more data, we could support things that older adults are going through, and also devise our care plans differently to support the medical needs of the individual. But of course, we work in the way it was perfectly designed to work, all in silos and never interacting. So 8 years ago, through a BIP innovation grant, we were able to test community care connections, which really took the social work services of the Aging Service Network. We added an LPN to help individuals with Medicaid reconciliation, with going to doctor's appointments for those who are medically complex, to just reinforce medical instructions for people and arrange transportation for them. Simple. I'm going to just say simple things. And when we did this, when we worked as a team, we also did a few other things. We got the New York Academy of Medicine to evaluate this interaction. We also developed a HIPAA-compliant form so that doctors could easily refer to us and put someone on the phone just for physician offices. And we also developed a closed-loop communication with the physician office. And when we did that, so today, over 100 physician offices, hundreds and hundreds of doctors will do a social screen, get that over to Lifespan for a social work assessment, the exact same assessment all of you do every single day. If they're medically complex, work as a team with the LPN, develop a care plan, and get that back to the physician's office. And we work together to stabilize individuals. The results are startling, and if anyone wants to see it, I have pages and pages of results, but I'm going to just, this is the drum roll slide. Thank you, Greg. And this is statistically significant reductions. When we do this work, when we integrate our services with healthcare, we can reduce hospitalizations by almost 20%, ED use by almost 1/3, and observations by 23%. We have been written up in 3 peer-reviewed journals that when you integrate the aging services that we do, and do this in a closed-loop fashion, you can get these kind of results. And these aren't just singular year results. We've been doing this over 8 years. But this is my favorite slide. And you know, I just picked the top 5. When you look at the things that make the biggest difference, it's high cap. I'm going to just say high cap. It's health insurance, yes. It's connecting people to benefits that we do every single day. It's PERS units, it's transportation, of course, and it's housekeeping. You know, it is all the stuff that we connect people to every day. This is consistent data year after year after year. These are the kind of results we get. And I kept challenging our staff in the beginning. I kept saying, that can't be. Like, how can financial counseling or high camp make such a difference? And they kept saying, well, it's so easy, Emery, if you would think about it, because we can reduce their stress. We can make sure their bills are paid on time. They can pick up their prescription drugs because they have enough money for the copay. They can do those things, and when you do that, it helps their outcomes. We really look at, I have to say, the quadruple aim: reduction in health care cost, connecting people to services, now in patient and physician satisfaction. We always have our evaluators talk to the physicians, and the quotes are incredible. Really saying, I didn't even know this kind of world existed where you could help my patients in this way. Still to this day, so think about that. They don't even know the broad, in-depth services we provide today. But a couple of other things, because of the support of Greg and Becky and everybody else, we are working now lifespan in the whole Finger Lakes region, so rural, suburban, and urban, and we're cutting the data in different ways, and it's holding, and also looking at race and ethnicity. We also partnered with Mary from Broome County, and I'm really bummed she's not here because she's doing such an awesome job replicating this program in Broome County and getting the same results. And we're partnering with Self-Help in New York City to say when we integrate aging services and we're getting the same results. Two things are coming up that you folks know. I'm like preaching to the choir here. We have the Medicaid 1115 waiver, the development of social care networks, and I know what you're all thinking. Most of my folks aren't in Medicaid, but we do have, because we track this all the time, about 25 to 30% duals in any given years. That Medicaid waiver should be paying for our services here. And the other thing I'm following very closely is the new Medicare physician fee schedule, which will also, should also pay for our services. Now think of Medicare, that's our sweet spot there for our services. So in the next couple of years, I'm trying to figure out how these funding streams can pay for the critical work we do, and no longer can they say, well, you don't have the data to prove that you make a difference, because we do have the data. What we need to do is use that. I have so much data, I could be up here, and I have so many quotes that I'm not going to tell you, physician quotes and client quotes, how they feel supported, and really looking at the whole person. So if anybody wants that data, I'm happy to share. I'm happy to share those peer-reviewed articles. I'm really just standing up here today to say our work makes a difference. And the innovation is really very simple. It's not changing what we do. It's connecting with healthcare and doing a few things differently to get the kind of results we need so that older adults can really thrive in the community, remain independent, and honestly expand our services, because that's what we need to do in the next few years. Thank you.
And Anne Marie gets the prize for staying under time, so I appreciate that. You might be surprised at the data, but you should not be surprised at the message. That's what we've been saying over and over again. And the reason we're doing this today is because, you know, there's so many incredible tools and partnerships that are being developed that we don't know what we don't know until we know it. And that's what we're trying to do here today. Becky and I swear, vet 2 to 3 tech companies a week going back to 2021. And this is really just the beginning because of how fantastic all these partnerships and additional tools are. And they do have an impact on the people that we serve to prevent additional stress and pressure on our system if we can help them in other ways. Get set up.